Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and today we are joined by our third host, Dr. Mike Clifford from Melbourne. Welcome, Mike.
Thank you, Swapnil. Hello.
How's things in Melbourne? Getting cold, I guess?
Yeah, it's quite a cold day today, but the sun's been out, so it's been lovely.
That's great. So, Maddie, we are going to start with renal physiology this time. We got a patient who is currently on dialysis, and your registrar has asked to comment upon functional anatomy of kidney. Can you walk us through functional anatomy of the kidney, please?
Yeah, sure. So I'd like to start first thinking about the gross anatomy of the kidney. So the kidneys are two retroperitoneal structures that are paired, and so they lie on the posterior wall of the abdomen. They're surrounded by a fibrous capsule, and the left kidney usually lies around the level of T12 to L3, but the right kidney is slightly lower because it gets pushed down by the liver. Each kidney weighs about 150 grams, and the medial aspect of the kidney is the hilum, and this is through which pass the vasculature, so the renal artery and the vein, the lymphatics, the nerve supply, and the ureter. Then coming to the gross and other anatomy of the kidney and its structure, there are two major parts of it. So these are called the cortex and the medulla. The cortex is the outer region of the kidney, and the medulla is the inner region. And the medulla is divided into multiple cone-shaped areas called pyramids. The base of the pyramid lies at the corticomedullary border, while the apex is turned in, and they're papilla, which project into a minor calyx, which is made of parallel bundles of collecting tubules. Several of these minor calyces then converge to form a major calyx, which then all join to form the renal pelvis. And this is a funnel-shaped area that then goes on to form the ureter, through which urine drains eventually into the bladder. Each of these pyramids are separated by connective tissue called the renal columns. And then we should think about the functional unit of the kidney. So the functional unit of the kidney is something called the nephron, which consists of the glomerulus and a long tubule. The glomerulus is formed by an invagination of a network of glomerular capillaries, which is then surrounded by something called Bowman's capsule. The glomerular capillaries are unique in that they have a higher hydrostatic pressure compared to the remainder of the capillaries. So this usually sits about 60 millimeters of mercury. And this allows for rapid fluid filtration, which allows for the kidneys to do their job. The glomerular capillaries are supplied by an afferent arteriole and drained by an efferent arteriole. And then the efferent arterioles then form a second capillary network, which also makes the kidneys unique, called the peritubular capillaries, which then surround the renal tubules. There are different types of nephrons, but there are specialized nephrons called the juxtamedullary nephrons, which have specialized peritubular capillaries known as the vasa recta. So when blood flows into the glomerulus, it's separated from filtrate in Bowman's capsule by capillary endothelium, basement membrane, and the epithelium of the capsule, which are termed podocytes. So this capillary endothelium have highly specialized fenestrations, which prevent cellular components of blood passing. The glomerular basement membrane does not contain pores and also contains something called mesangial cells, which contract and can help regulate glomerular filtration. And finally, the epithelial cells of Bowman's capsules, otherwise known as podocytes, have these foot processes which interlink and create a large surface area. They also have a thick negatively charged glycocalyx, and this helps prevent proteins from entering the filtrate. So all of these substances then help the kidneys to filter the blood and keep proteins out of the filtrate. Fluid that's then filtered into Bowman's capsule then joins to become the proximal tubule, which is made up of a single layer of cells with apical tight junctions, and this reabsorbs a large volume of fluid and electrolytes. This then flows from the proximal tubule into the loop of Henle, which consists of a descending and an ascending limb. So the descending limb and the proximal ascending limb also have thin cells which help to absorb water. The descending and the proximal ascending limb go into the renal medulla, and the descending limb is highly permeable to water and moderately permeable to solutes, and this allows for diffusion of these substances. The distal part of the ascending limb consists of thick cells, and this is known as the thick ascending loop of Henle. And it's here that a lot of solutes are reabsorbed, including sodium, potassium, chloride, and bicarbonate, and hydrogen is secreted. But the ascending limb is virtually impermeable to water, but it reabsorbs a significant amount of these solutes by the sodium 2 chloride potassium proton transporter, which is important because it's what furosemide works on. This, coupled with the specialized parallel vessels of the vasa recta, allows for a countercurrent mechanism to occur, which then allows for urine to become concentrated. So this is another important part of the anatomical structure of the kidney that allows it to function and make concentrated urine. At the end of the thick ascending limb is a small segment of cells known as the macula densa, and this plays a key role in sensing luminal sodium chloride concentration and responds appropriately to maintain appropriate glomerular filtration and renal blood flow. Fluid then enters the distal convoluted tubule and then the collecting ducts, which eventually coalesce, as we've talked about before, to empty into the renal pelvis and then the ureter. So that's the main growth structure and functional anatomy of the kidney. But part of the next thing I think to think about is what the blood flow of the kidney is like and how this is maintained, which would especially be important in the critically ill population. So Swapnil, can you tell me a bit about the blood flow to the kidney and its regulation?
Yeah, that's right, Maddie, because renal blood flow is really important topic. I guess kidney is one of the most important organs in the body, which receives around 1/4 of the cardiac output. So if a cardiac output is roughly around 5 liters per minute, kidneys receive 1.25 liters per minute of blood flow. Now, the renal blood flow is really proportional to pressure gradient. And the pressure difference between the renal artery minus pressure between the renal vein divided by the resistance in the renal arterioles. And that leads to calculation of renal blood flow. So any factor which affects the pressure in the renal artery or resistance in renal arterioles will affect the renal blood flow. Now, as you mentioned within the functional anatomy, renal artery supplies the blood supply to kidney, which then kind of goes into this afferent arteriole through the different divisions of arteries and then end up in afferent arteriole, which forms the glomerulus and then terminates into the efferent arteriole. Now, the efferent arteriole forms the different peritubular capillaries, which play important role in creating the concentration gradient across the medulla and cortex. And then subsequently, this peritubular capillary is joined to form the renal vein, which drains into inferior vena cava. Now, when you look at the overall regulation of renal blood flow, the key things that regulates renal blood flow is determined by the pressure gradient, as I mentioned. And so any increase in blood pressure will increase the pressure in the renal artery, will increase in the renal blood flow. Similarly, anything that decreases the arterial resistance will increase the renal blood flow. Now, the renal blood flow determines the GFR. So whenever there's an increase in renal blood flow will lead to increased GFR. So basically, the regulation of renal blood flow kind of plays around increasing or decreasing the arterial resistance. Now, there are key hormones which play important role in this process. So the hormones which lead to increased arteriolar resistance, which in turn decreases the renal blood flow, include adrenaline, which is secreted by adrenal gland in response to sympathetic stimulation, which in turn binds to alpha-1 adrenergic receptors along with afferent and efferent arterioles, which lead to smooth muscle contraction. So increases the resistance, decreases the renal blood flow. Similarly, angiotensin 2. Now, the renin is produced by the juxtaglomerular cells in the afferent arteriole, which gets released into blood, becomes the angiotensin 1 in response to low blood pressure, subsequently gets converted into angiotensin 2 by angiotensin converting enzyme, which is synthesized in endothelial cells, especially in the lungs. Now, this angiotensin 2 binds to angiotensin receptors along the afferent and efferent arterioles, again leads to smooth muscle cell contraction, increases the resistance of arterioli, and then in turn leads to decreasing the renal blood flow. Now, efferent arterioles are more sensitive to angiotensin 2, thus leads to more constriction, while the high levels of angiotensin 2 results in afferent arteriolar constriction, which in turn decreases actually the GFR. Now, the hormones that play a role in decreasing arteriolar resistance and thus lead to increasing renal blood flow include atrial natriuretic peptide, ANP, which is secreted by atria of the heart in response to increased cardiac workload or stretch. This binds to natriuretic peptide receptors along the afferent and efferent arterioles, and it leads to smooth muscle cell relaxation. Similarly, BNP also leads to smooth muscle cell relaxation. Other hormones which play a role are prostaglandins, prostaglandin E2 and I2, which are also produced by kidneys in response to sympathetic stimulation. These bind to prostaglandin receptors and leads to smooth muscle cell relaxation. Usually, prostaglandins play a protective role because they prevent kidney damage during the sympathetic stimulus. Dopamine also is thought to play some role in renal blood flow regulation. It binds to dopaminergic receptors and causes smooth muscle cell relaxation. And that was the kind of postulation or hypothesis before where we used to use dopamine as the renal protective agent, which was turned out to be myth, and we stopped using dopamine in ICU anymore. Coming back to the autoregulation of renal blood flow, which basically keeps the renal blood flow and GFR constant over the range of systemic blood pressure. And this range is usually from 80 millimeters mercury to 200 millimeters of mercury. Below 80 millimeters of mercury, smooth muscle cells in the blood cells completely relax. And at kind of that 80 millimeters mercury, the blood flow is optimal. As systemic blood pressure increases, that leads to smooth muscle cell constriction. And then there are two different mechanisms of autoregulation. One is the myogenic mechanism, and second is the tubuloglomerular mechanism. Now, myogenic mechanism is where smooth muscle cell in arterioles automatically constrict or relax in response to blood pressure and adjust the renal blood flow. While the tubuloglomerular feedback mechanism, where macula densa cells release adenosine, this increases the resistance in afferent arteriole when more sodium or chloride ions are detected in the distal convoluted tubule, which happens in response to increased GFR or increased renal blood flow. So as a result of that, the adenosine increases the arteriolar resistance, and then that leads to decreased GFR. So these are the kind of mechanisms which are in play to control or maintain that renal autoregulation. In terms of the another question which we commonly ask is, how do you measure renal plasma flow and renal blood flow? Usually we use Fick principle, which is basically amount of substance in the blood that flows into organ is equal to amount of that substance flows out of that organ, provided that that organ does not contribute to production or degradation of that particular substance. So in order to estimate the renal plasma flow, we usually use para-amino hippuric acid or pH, which is obviously not made in the body and does not affect renal function. And then you use the Fick principle to calculate the two renal plasma flow. Now, you can use some assumptions to calculate effective renal plasma flow, where basically 90% of the pH leaves the kidney in urine, while 10% leaves in the renal vein, which is negligible. And based on that, you can kind of calculate or estimate the effective renal plasma flow. And then the renal blood flow is nothing but renal plasma flow divided by 1 minus hematocrit. So based on the renal plasma flow, then you can calculate the renal blood flow. So that's the main thing about the renal blood flow. Now, I guess the important question is obviously this person who has got acute kidney injury in ICU, and we use a lot of drugs in ICU, which potentially can be impaired by renal failure. So, Mike, can you walk us through the impact of renal failure on the drug clearance?
Yeah, sure, Swapnil. So, look, this comes up again and again in the SICM exam in the primary, and candidates have been warned about saying things like hepatically metabolized and renally cleared, because we really want them to tell us whether or not the kidney is important in that drug excretion. So I'm glad you've raised the concept of renal blood flow versus renal plasma flow, because that sort of comes down to exactly where the drug is being cleared from. So if you take a step back, of the top 200 drugs out there in the market, about 1/3 of them have a significant component that is renally excreted or cleared. And about 1/4 of those actually need dose adjustment. So for any sort of list of drugs, about less than 10% of them are actually requiring dose reduction. Now, in ICU, that number might be a little bit high, but it's still a small number of drugs overall that we use, where we actually have to stop and think about whether or not we need to actually reduce the dose of the drug we're giving. And that's often because they have a wide therapeutic window. So it's quite safe to give them in relative overdose. And the classic of those would be all of the antibiotics, where we really don't have to change the dose until our renal function is significantly depressed. So one of the things that I try and tell people is, if you don't know where a drug's being metabolized or cleared, then have a look at its overall clearance. And if the clearance is less than 2 mils per kilo per minute, you sort of know it must be limited to glomerular filtration. And that just comes from the overall numbers. So as we've mentioned, the kidneys get 20% of cardiac output, which is about 1,000 mils per minute. And if we divide that by 70 kilos, you get 14 mils per kilo per minute. Now, that's renal blood flow, but as you alluded to, that's not renal plasma flow. So if we multiply renal blood flow by 1 minus the hematocrit, that reduces it down further to about 8 mils per kilo per minute. But of that renal plasma flow, only about 20% of it is actually the filtration fraction, or the GFR. So if you multiply 0.2 by 8, you get about 2, right? So 125 mils per minute, which is your GFR, that works out when you divide it by 70 to be about 2 mils per kilo per minute. So that's your glomerular filtration rate. So if a drug's being cleared from the body at a rate less than that, it's almost certainly being just filtered by the kidney. Now, the kidney doesn't just filter drugs, obviously. A significant component of the renal metabolism is actually secretion. And we've become more interested in that over the last few years because we've found that many of the interactions that occur with drugs at the level of the kidney are occurring through some of these organic acids and base secreting pumps. And I'll come back to that. But you do need to have a bit of an estimate about renal function to work out whether or not you do need to reduce your drug doses. And when drugs are put on the market, the formula that the drug companies have to use is an estimate of creatinine clearance, and they use the Cockcroft-Gault method, okay? Now, we're used to in ICU seeing estimates of creatinine clearance either using that particular formula or more commonly an eGFR is given to us. And the eGFR was a modification of a estimate of creatinine clearance from a long-term renal study looking at a dietary reduction to protect kidneys. So it only looks at the serum creatinine, your age and your gender. It doesn't take into consideration your size or your sex, okay? And the eGFR is therefore per 1.73 metres squared. So it's a estimate that's based on the generic sized person, and that's why it's less accurate. So the drug companies have to use the Cockcroft-Gault formula, which is that the creatinine clearance equals 140 minus your age multiplied by your lean body weight, right? Your lean body weight multiplied by a cofactor, if you're female, of 0.85, divided by your serum creatinine in micromoles per litre, multiplied by another factor for the units, which is 0.815. So essentially you have this number that is age dependent, a function of your total body muscle mass, which is you can estimate from your height and weight, and then a cofactor for your sex. So women have slightly less lean body mass than men. So that's where the Cockcroft-Gault formula comes from, and it gives you an estimate of your creatinine clearance, and that's what drug companies use when they tell you you need to reduce your doses when you get below a certain level, okay? So if you've got significant reductions in creatinine clearance down below 60 or 30 mils per minute, then you need to start thinking about whether you need to reduce some of the drugs you're administering. And it might well be drugs that are excreted by the kidney or filtered by the kidney and not reabsorbed with a narrow therapeutic window. And the drugs that leap to mind there are the aminoglycosides and vancomycin. There's also the carbapenems and the tertiary penicillins like piperacillin. All of those drugs are actively secreted or are limited by the amount that they're filtered. So those are the sorts of drugs you might want to think about reducing when your kidney function's going off. Many of the antivirals freely filtered by the kidney. Some of our water-soluble, non-protein-bound cardiac drugs like atenolol and sotalol and even digoxin. And there's also many of our psychotropics and some of our opioids and opioid metabolites, in particular morphine 6-glucuronide, which is purely filtered by the kidney and as a water-soluble metabolite from the liver. So if your kidney function goes off, those are the drugs that you need to think about whether or not they're going to accumulate in your patient and you need to reduce your doses. There are many drugs that if you look at the information around them will suggest that you reduce them in the setting of kidney function, but it's actually a relatively small number of drugs where you actually have to reduce them in the ICU setting. And just on thinking about drugs that are actively secreted, and one of our most common drugs is frusemide, which is secreted by the organic anion transporter protein, and that's how it has a high concentration in the lumen where it binds to its protein target. That's inhibited by probenecid. So probenecid was an interesting drug that was very popular in the olden days when we needed high concentrations of penicillin in the urine, or we wanted to collect as much penicillin as possible and not have to keep dosing it. It was a way of limiting the total amount of penicillin you had to give a patient because it would block the protein that excreted penicillin from the body so you could have a higher blood level for any given dose. I mean, it's sort of gone out of favour now, but that was one of the original uses of that drug. And probenecid because it binds to that organic acid transporter protein, blocks a lot of drugs that get secreted in that way, including things like methotrexate and folate. So it's a non-specific blocker. The organic cation transporter protein, which is also responsible for excreting creatinine, is blocked by cimetidine. So that was a drug that caused inadvertent elevations of drugs that were secreted by that protein, and that could include things like metformin or cisplatin. And these days, when we do in oncology, they often do genetic analysis of that protein subtype to see how much, whether you're going to be safely able to have those drugs. So we're down into the realms of personalised pharmacotherapeutics now. But taking a step back, those are the sorts of questions you're asking when you're thinking about whether or not you need to reduce the renally filtered or renally excreted drug. It comes down to what is my therapeutic window and how much do I have to adjust, and then how much renal failure do I have, and am I down at the level where I've got less than 50% renal function, which is when I will start to see some accumulation of these drugs. And the probably the most common one where you would adjust every day would be low molecular weight heparin, where its metabolism is dependent and its secretion in the kidney is dependent on having adequate renal cell mass. So it's one of the agents that has a narrow therapeutic window. You don't over-anticoagulate them. It's safe for most patients who have even a little bit of renal impairment, but once they get below 50%, you start to see significant alterations in your low molecular weight heparin activity because it hangs around. So that's a bit of an overview of renal clearance and how it's affected by renal impairment. But I think what you should do as candidates is have a list of drugs where the renal excretion is the major metabolic pathway, so that you've got a small handful of drugs that you can communicate to both examiners and to your colleagues in ICU about which drugs you need to dose reduce in the setting of significant renal failure.
Yeah, that's a very good point, Mike. I guess often we kind of obviously look at the ETG guidelines or what are the resources available in your hospital to adjust these medications. And I guess it's just that having that awareness about which medications need dose adjustment, that's very useful. I guess that's pretty much the content while we are going to cover today in the podcast. We're coming to the last section of the podcast, which is Maddie's section. Maddie, do you have a joke?
I do. It's a bit left field in that it kind of, I don't know, I'll explain after. But yeah, I do. Okay, so why would Cleopatra never admit she was wrong?
I can see Mike is already scratching his head.
That would be too nihilistic of her. No.
Oh, pretty close. Yeah. She was the queen of denial.
Oh, so close. That's good.
I don't know. It's not really that. I mean, because I thought today is like the Queen's birthday, and also I kind of was thinking about renal pyramids and stuff, and then pyramids, Cleopatra, sort of. I don't know. It's a long bow.
And the Nile is just more water moving through, so we can pull it all together, man. Yeah. Well done.
It's all relevant.
I can see that probably the more thought process goes in designing the joke than actually writing the content for the podcast.
Oh yeah, the content's way easier.
Well done, Maddie. So thanks, folks. So thanks, Maddie, and thanks, Mike. So I guess that's the end of our today's episode for this month. We'll be back in 1 month's time with another episode. So till then, goodbye and have a nice time.
Thanks for listening.
See you later.
See you next time.
Thanks, guys. Bye.